The next 25 minutes I am going to discuss regarding the analysis of body fluids. In a chemical pathology lab, as you all know, we received many human body fluids such as whole blood, plasma or serum, and urine, CSF fluid, saliva, synovial fluid, pleural, pericardial and ascitic fluid, as well as amniotic fluid. Among these body fluids, I am not going to discuss about whole blood and plasma, but other things I will discuss in detail. This is a urine strip test. As you all know, you have know these things. When you consider urine, the commonest requested urine analysis is the full report of urine, that is UFR. We have to, there are some common things that should be appeared in all the urine analysis UFR report. That is the appearance. You have to write whether it is clear, turbid, or is there any specific color. And the reaction, it should be basic or acidic. Usually it is pH, usual range is between the pH range of 5 to 6, and the presence of protein, mainly albumin, and sugar. So in sugar we have to mention whether it is reducing or non-reducing substances. Method is different from the reducing and the non-reducing substance. When you, if there is any bilirubin, that is totally it is pathological because it can be appeared in hepatocellular disease or cholestasis. This bilirubin is conjugated bilirubin because unconjugated bilirubin is bound to protein, and usually it is not filtered through the glomerular to the urine. And the urobilinogen. Urobilinogen, usually it is present. Usually means it is always present. Therefore, you have to mention whether it is present in normal amounts or increased or decreased. It is increased in hepatocellular disease and in hemolytic anemias, and it is decreased in cholestasis. When we go to deposits, there are so many deposits. We had to mention whether there is red blood cells, pus cells, or epithelial cells. Epithelial cells, usually you can see the epithelial cells, but if the epithelial cells present in large numbers, that is pathological. Then the cast. There are red blood cell cast, granular cast, hyaline and epithelial cast. Granular cast are present in degeneration of tubular epithelial cells, and hyaline cast are present in albuminuria and after exercise. Epithelial cast you can see in tubular damages. Then the organisms. Then the main part of urine analysis is crystals. There are many crystals that you have come across in your career. I'll discuss some of them. One is the triple phosphate, that is ammonium magnesium phosphate. You can see it in alkaline urine with bacterial infection, and in contamination of urine also you can see the triple phosphate crystals. It shapes like a coffin lid or can be feathery in appearance also. Then the calcium phosphate. It is rosette or star-shaped crystals. It is usually present in alkaline urine. And amorphous phosphates, it is a colorless crystal and dissolves in diluted acetic acid. Uric acid usually present in aciduria. It is a colored component. It shaped as a rhombic prism and dissolves in sodium hydroxide. So if you have come across these crystals, you can, for example, if you have seen a rhombic prism, you can confirm whether it is a uric acid by adding sodium hydroxide, and if it dissolves, definitely it is a uric acid crystal. That's why I have written those things. So you can confirm by the other testing also, not looking at the shape only. There are methods to confirm the crystals. In urate, it is present in acidic urea and it is stellar shape. Calcium oxalate can be present in both acidic and alkaline urine. It is octahedral or envelope shaped. Calcium carbonate, it is rarely seen and present in alkaline urine. It is dumbbell shaped. Calcium sulfate, it is also rare, present in acidic urine and it is needle shaped. Cysteine is also rare, hexagonal plates and it's colorless. It dissolves in acids. Leucine and tyrosine is also rare. You can see it in severe liver diseases. It appears as tufts of fine needles. And usually urine specific gravity is between 1.002 to 1.030. These are the shapes of the crystals that I have mentioned earlier. This is leucine crystal, this is sodium urate and tyrosine needles, cysteine crystals, amorphous urates, calcium oxalates, uric acid crystals, and this is those are present in these things are present in acidic urea. And in alkaline urea, you can see triple phosphate crystals, calcium phosphate crystals, ammonium urate crystals, calcium carbonate crystals, and amorphous phosphate. There are other requested tests in urine samples. Clinicians may ask for ketone bodies. Ketone bodies in our body, there are three types of ketone bodies: acetone, acetoacetate and beta hydroxybutyrate. Rotheras detect mainly acetone but not beta hydroxybutyrate, and but the beta hydroxybutyrate is the main component of diabetic ketoacidosis. When they started treatment for ketoacidosis, this beta hydroxybutyric acid converted into acetone. So in the first sample you may get less positive for Rotheras test. If someone send you a urine sample of a ketoacidosis patient that is not treated, the positivity for ketone bodies in Rotheras test is very low. And then when they started, you will get a strong positivity for Rotheras test. That doesn't mean the patient condition getting worse, but it means that beta hydroxybutyrate is converting to acetone. So the patient is now treating. So and the other test they ask is for multiple myelomas. For Bence-Jones protein, we can do Bradshaw test, but in multiple myeloma, heat test is more definitive than the Bence-Jones protein or the Bradshaw test. And also we can do the urine electrophoresis. For urinary proteins, the reference range is 20 to 150 milligrams per day. Majority of which is albumin. In 24-hour urinary test, we can do creatinine clearance, urine proteins, urine calcium and phosphate, uric acids, cysteine and oxalates, and electrolytes also. In urine microalbumin, it is detected in diabetic nephropathy in early stages. This detects the small amount of albumin passed, which is not detected by the conventional method. Microalbumin per se, when you consider this word, it is not a special type of microalbumin. It is the same type of albumin which is present in the serum, but it present in very minute amount. That's why we are telling it's microalbumin. In early morning spot urine sample is the best. and it has given as a ratio with urinary creatinine. Urine is used to diagnose certain amino acid ureas in inborn errors, especially in inborn errors. Amino acids in urine are separated following chromatography, and we can use urine to detect drugs of abuse. For this, serial urine samples are needed. Then we will move into cerebrospinal fluid. This is the second commonest test among the body fluids that we are getting into our laboratories. They also, mainly they request for full report or for malignant cells. In components in a full report, appearance is normally clear and colorless. If it has instead of clear or colorless, if it has a red color or yellowish color, that means it's pathological. Cell count, usually there's no red blood cells, no white blood cells, and usually lymphocytes can be there present in 0 to 5. Protein level is 15 to 45 milligrams per deciliter. This is very important in diagnosing diseases. Glucose is present 2/3 of the concurrent random blood sugar. That means if you get a random blood sugar of a CSF fluid, if they request, usually the clinicians should send a sample of random blood sugar at the same time they acquire the CSF fluid, because the concurrent, it is CSF glucose level equals to 2/3 of concurrent random blood sugar level. So if we have get the random blood sugar level of 150 and we get a CSF sugar level of 100, that means our analysis is correct. Then we can diagnose the diseases when you consider the total protein and the appearance. Such as in bacterial meningitis, the appearance is turbid or purulent, and polymorpholeukocytes are more than 500. Total protein is 800 to 500. As you've seen in the earlier slide, the usual normal level of protein in CSF 15 to 45 milligrams per deciliter, but in bacterial meningitis it is 80 to 500. In cryptococcal meningitis, it is clear or turbid, and 50 to 150 polymorpholeukocytes or lymphocytes can be seen. Total protein level is lesser than the bacterial meningitis. It is between 25 to 200. So it may range within the normal level also, because up to 45 CSF protein is normal. So only in bacterial meningitis is having the higher number of protein. In viral meningitis also, the appearance is clear and colorless, and there may be there's no polymorpholeukocytes, but lymphocytes are there. There can be up to 500 lymphocytes, and the total protein level is 30 to 100. In poliomyelitis, same as the viral meningitis, total protein level is slightly higher than the viral meningitis. It can be ranging from 10 to 300. In brain tumors, appearance is clear. There are lymphocytes ranging from 0 to 80, and total protein is 15 to 200. In neurosyphilis, appearance is clear and it is colorless. There's lymphocytes 10 to 100, and the total protein is 50 to 150. In multiple sclerosis, it is clear and colorless. There may be 0 to 10 lymphocytes, and total protein is 25 to 50. In tuberculous meningitis, you can see a characteristic cobweb appearance with the range of lymphocytes 50 to 100, and total protein can be range from 55 to 300, and it can go up to 1000 even. In brain abscess, the appearance is clear and it is slightly turbid. Total protein is 20 to 120. So, when you, with your analysis, you can guess what is the disease that the patient is having. CSF electrophoresis. The main purpose of electrophoretic separation is to detect the oligoclonal IgG band that appears in multiple sclerosis. But as you know, in multiple sclerosis, the total protein level is 25 to 50. That means it's very low level. So we have to concentrate the CSF protein and then do the electrophoresis, otherwise we are not going to get a band. So the both concentrated CSF, we had to concentrate it 40 to 60 folds, and the diluted serum should be run in parallel, then only we can see the extra band in the CSF protein. A prominent prealbumin band and two transferrin band are the most striking features. The second transferrin band is called a top band, is produced intrathecally. This helps to differentiate the cerebrospinal fluid from other discharges. So if you get rhinorrhea, that means if you get CSF, if you get a brain skull base damage, you may get water discharge from your nose. So if you are not sure whether it is CSF or other fluid, you can do electrophoresis, and if you get a second transferrin band or the toe band, you can confirm it that is CSF, not another fluid. There is a special stain for CSF electrophoresis. You have to use silver stain or paragon violet. CSF chloride levels are usually 15% higher than the serum level. When you move into synovial fluid, to characterize the type of arthritis and to differentiate the non-inflammatory or the inflammatory effusions, we have to analyze synovial fluid. In a normal synovial fluid is colourless or clear, and the viscosity is high. There are nucleated cells ranging from 13 to 180 per microliter, and the differential count can be, there can be neutrophil 0 to 25%, lymphocytes 0 to 78%, and monocyte 0 to 71%. Red blood cells, there can be 0 to 2000 per microliters, and there are no crystals in a normal synovial fluid. In pleural and ascitic fluid, the biochemical testing of peritoneal and pleural fluids is carried out widely, although the range of tests likely to be useful is limited in comparison to the repertoire of the tests available in the modern biochemistry laboratory. Fluids accumulate when pathological processes cause an imbalance between the hydrostatic pressure gradients. So the capillary membrane permeability and the lymphatic capacity is altered, and it will result a protein poor transudate or inflammatory exudate. These will be accumulated in pleural or the ascitic cavity. In peritoneal fluid, albumin is the most useful test for the calculation of serum to ascitic albumin gradient. Protein and LDH have a role regarding risk and the diagnosis of spontaneous bacterial peritonitis, and amylase may be useful in diagnosing fluid accumulation due to pancreatitis. Peritoneal fluid pH and glucose are not indicated in analysis. For pleural fluid, protein and LDH are important in distinguishing between the transudate and the exudate using the Light's criteria. Albumin and the serum effusion albumin gradient may have a complementary role in patients already on diuretics. Pleural fluid pH is the most useful marker for infection, but the LDH and glucose are also used. Pleural fluid amylase is often measured, but if it is raised, it is more likely to reflect a malignant process than a pancreatic disease, as the former is much more prevalent. That means if you get positive for amylase in a pleural fluid, it has more chance to be a malignant disease other than a pancreatic disease. Tumor markers in both peritoneal and pleural fluids generally have limited diagnosis accuracy for detecting local malignancy. So, we are not going to perform tumor markers in peritoneal or pleural fluids. When you consider the gross appearance and the paracentesis biochemistry, usually the color is pale to yellow. That is a normal color, and if it is cloudy or turbid, it can be a malignant tumor, lymphoma or TB, or parasitic infection or cirrhosis. If it is milky colored, peritonitis can be suggest, also bacterial infection, bowel perforation, pancreatitis and bowel infarction are possibilities. If it is a blood tap, it can be a benign or a malignant tumor. If the triglyceride level is elevated, usually it is malignant tumor as well as lymphoma, tuberculosis, parasitic infection or cirrhosis. If the protein level is between 0.3 to 4 grams per deciliter, that is normal. If it is more than 4 grams per deciliter, that indicates it can be TB or peritonitis. And the normal glucose level is 7 to 10 millimoles per liter, and if it is less than 6 millimoles per liter, that means it is TB or malignancy. If the amylase level is 50% of the serum level, that is normal. If it is increased up to 5 times or more, that indicates pancreatitis, pancreatic pseudocyst, pancreatic trauma or intestinal strangulation. If ALP level is increased, suggestive of small bowel perforation and strangulation. When you go into amniotic fluid, very rarely we are getting amniotic fluid analysis. It is analyzed for suspecting congenital abnormalities, to assess fetal maturity and Rh isoimmunization, and to detect intrauterine infections. Saliva also we are getting very rarely, but in Western countries, fairly a good number of samples we are getting to the lab, the saliva testing. You can use saliva to detect blood group substances to determine secretory status and the genotyping, and in hormone assays, especially cortisol. And we can use it for the measurement of drug levels. Take home message what I want to give you is, fluid analysis is very important in differentiation of a diagnosis and to monitor the response for the treatment. Therefore, we may get serial analysis, and delta check-in will help to issue an accurate report. That means if you get a serial analysis of the same test, that means it's better if you look for the previous value of that same report and then issue the report. Then we can with that thing that is called delta check-in, we will be able to release an accurate report. In manual analysis, individual person skills also play a major role if you are doing in manual. These are the references that I have gone through. Thank you.